Welcome back to Pharmacology with Dr. Sokolow, and this is the second module on diabetes, and now we are going to talk about the treatment approach. So let's talk about the insulin therapy. There are 7 types of insulin, and this is a very important slide, very important for your board exam. You need to know which insulin is a rapid acting and which one is a long acting. What is the difference? When do you give a rapid acting versus a long acting one? So the first 3 are insulin lispro, aspart, and glulisine. These are the rapid acting, so they have an onset of action within 30 minutes and a short duration of action between 3 to 5 hours. And so therefore they are going to be administered before meal, and these are the ones that are used to control the postprandial rise in blood glucose. Now you have the regular or short acting, so have an onset of action between 15 minutes to an hour and a duration of action between 6 and 10 hours. So you see it's a little bit longer. And this one is administered 30 minutes before meal to control the postprandial hyperglycemia. And this is the regular insulin. This is the natural insulin. And this is the only insulin also that can be given IV. So an IV drip, that would be the regular insulin. Now, the intermediate acting has an onset of action between 1 and 2 hours, and their duration of action is between 14 to 24 hours. So this one is to control the baseline. So these are called the baseline insulin. So it's administered once or twice daily and provide the basic glycemic control. And this is the neutral protamine, or NPH, insulin in pH. So you don't need to know the brand name like Humalog, Novolog, Aprida, or Humulin, Novolin. It's not necessarily for my class, but in the hospital sometimes they use the brand name rather than using the terminology. So if you know both, it's very useful. So, and then the last type of insulin is the long acting, has an onset of action of 70 minutes, and the duration is between 14 to 24 hours, so basically a day. So this is also a insulin that will provide, you know, like baseline glycemic control, and this one is administered once daily at bedtime, and you have 2 insulin detamere or insulin glargine. And you have to be careful that insulin detamere should not be mixed with any other insulin because it will precipitate. So the dosage and the type of insulin that the patient will receive is going to be determined by the physician, and it's going to depend, on the weight of the patient and also on his or her plasma glucose level. The unit that they need can vary, and they have to monitor their blood glucose. And so this one is a graph showing the different half-life, or the duration of those different insulin. So you see you have the short duration rapid acting, so insulin, lispro, and glulisine. Then you have the slower acting, so this is your natural insulin. Then you have the intermediate duration, your NPH, and then you have the long acting. And so in terms of administration, so the most common route is the subcutaneous injection that can be self-administered, and you have the new injectors, so the pen injector, that are very easy to use. If you are using a pen injector in the hospital, make sure that you do not share between patients. The subcutaneous injection, usually syringes will be pre-filled by the pharmacy and brought to the floor as a pre-filled syringes, but you may have to determine how many units your patient needs to receive. Then you have the subcutaneous infusion. So now you have portable insulin pump and implantable insulin pump that is for, outpatient setting, that is more, convenient for the patient because they don't have to inject themselves several times a day, and they have the pump that regulate and monitor their, insulin infusion, injection. And so it's also like useful for kid at school, as this is more convenient way to administer the insulin. Now, intravenous infusion, the IV drip, that's for the inpatient setting, for the emergency. That's the one you'll see, in the hospital. Often doesn't mean that you don't see the other for the baseline control, but you will see some patients that will be on insulin drip. And then inhaled insulin, even though it was a great idea to reduce, the adverse effects of, the fatty deposit at the site of injection and the pain at the site of injection, they started to manufacture an inhaled insulin, but of course it was, not cheap because it was new, and then it didn't really hit the market like they were hoping. So the pharmaceutical company just decided to stop the production and is no longer available. And so for the dosage, so it's for your information only, but you may probably need to know this in other classes. You see that the daily dose is different between type 1 and type 2. So type 1 diabetes is between it's 0.5 unit per kilo per day, and it's 3 to 5 injection per day. Versus the type 2 diabetes, the dose is a little bit lower, 0.15 to 0.4 unit per day per kilo, and is 1 to 5 injection per day. So it's also like depending on how severe the type 2 diabetes is in the patient. Now, insulin sliding scale, this is something that you have to get familiar with, because in the hospital, if you are in charge of diabetic patient, you have to monitor their glucose level, and depending if they are in the range or not, you may need to supplement your patient with insulin if their baseline insulin is not sufficient. You may have to give them some extra unit during the day. And so you see you have three. So this is an example from a hospital where I did an internship. And so you see you have low, medium, and high dose. So this will depend on the patient, comorbidities, weight, and so what the physician will prescribe, and you're going to have to look if your patient is under a low dose, medium, or high dose. And then when you check their blood level of glucose, if you see that it's above 251 and lower than 300, if the physician requested a low dose sliding scale, you would have to give 6 units. And I have those documents here. I will review them with you in class. These are like the full protocol. And also I work on an audit, because what you want to avoid in the hospital is your patient to become hypoglycemic, which is a emergency situation if they go to a level of glycemia that is very low. And so you want to avoid that. And so we kind of look at patient, what was the cause of those patients who were going under like severe hypoglycemia, and how we can avoid, and see if we needed to review the insulin sliding scale. So I'll discuss that in class. But so now I have a little like case study. So try to keep in mind 2, 4, 6 unit and 10. And you are taking care of a patient that is on the low dose sliding scale. So your patient is a 63 years old female. She was admitted to the ICU, and you see she has a BMI of 30. So she's obese, moderate kidney disease, history of heart failure, diabetes, hyperlipidemia, hypertension, COPD, and AFib. And she's on 3 liters of oxygen at home. So these are all of her comorbidities. And now at 2000, you measure her glucose level, and she was 335 milligram per deciliter. So how many units of insulin does she need to restore her blood glucose level? So if you go back, I'm not going to go back now, but it was 8 units of the regular insulin. And now per protocol at 9 o'clock, so 2100, she received her scheduled insulin, which was 17 units of Lantus, so her long-acting insulin. And then at midnight, the nurse checked her, again, she checked her glucose level, and she was 230 milligram per deciliter, so she was still too high. And then, so that means the nurse gave her 4 more units of regular insulin. And guess what? At 3:50 a.m., her blood sugar was below 40 milligram per deciliter, and then she needed to be treated with D50 water IV per protocol. Why? When we look back, at this case study, we saw that she received basically 8 and then 17, so that was 29 units of insulin in a very short period of time, even though this one, was an insulin Lantus and long-acting one. And so that's kind of why we decided to look at our protocol and see how that can be revised and see how we can avoid this. Now, what are the adverse effects of insulin treatment, and what are the potential interaction with other medication? So adverse effect, of course, hypoglycemia. Insulin is an hypoglycemic hormone. So you give insulin, you are at risk of hypoglycemia, as you can tell by the previous case study. So lipodystrophy is deposition of subcutaneous fat at the site of injection. In those patients, they have to inject themselves several times a day. And sometimes it can cause allergic reaction. It's rare, but that can happen, and you can have either local or sometimes more severe allergic reaction with anaphylactic reaction. Now, drug interaction, of course, any hypoglycemic agent increase the risk of hypoglycemia. As I said, those agents are not used in type 2 diabetes, but insulin can be used in synergy with some oral hypoglycemic in some type 2 diabetes patient. And then if you have a patient who is taking some medication that has hyperglycemic effects, such as the thiazide diuretic, the glucocorticoid, then it will counteract the insulin effect. Now, let's talk about the oral hypoglycemic drugs. So there are like 7 types of agent. You have the old one, and then you have the newer one. The older one are the sulfonylurea, the meglitinide, the biguanide, the thiazolidinedione, or TZD, or we call them glitazone. Then you have the alpha glucosidase inhibitor, and then the newer agents are the DPP4 inhibitors and the SGLT2 inhibitors. So again, these drugs, they are only indicated for the treatment of type 2 diabetes, not type 1 diabetes, because remember, type 1 diabetic patients need to have insulin therapy. So let's talk about the first class of agents. So you have the insulin secretagogue. So what is a secretagogue? This is an agent that stimulates the release of insulin from the pancreatic islet. So they will promote the reduction of the blood glucose level. And of course, you have a risk of hypoglycemia because they stimulate the release of insulin. And this is inactive if the pancreas is unable to synthesize the insulin. So this drug doesn't work. Again, they don't work in type 1 diabetes patient. And you have two types of secretagogue. You have the sulfonylureas and then the meglitinides. Sulfonylurea, the first generation, still in use today. It's chloropropamide, and then the second generation, they have fewer adverse effects, but same mechanism of action, which is to stimulate the release of insulin. These are glyburide and glipizide. So these are, very, very common oral hypoglycemic drug. Now you have the meglitinides, repaglinide, lateglinide, so you see they have the same ending. Adverse effects, they have the same, adverse effect. They can cause hypoglycemia. And one thing that is unfortunate is weight gain, because again, you have your patient who are most likely obese and you want them to lose weight, and those two classes of drugs have a tendency to make your patient gain weight. Now the next next category is the insulin or the insulin synthetizer. So they increase the sensitivity of the receptor to the insulin, so they actually reduce the insulin resistance. So they increase the muscle and the adipose tissue sensitivity to insulin. They will increase the glucose uptake by the muscle and the adipocyte, and therefore reduce the blood glucose level. Again, to have an effect, the insulin must be present, which means they don't work in type 1 diabetes patient. And so the first class of insulin synthesizers is the biguanides. So metformin, very common drug, usually is the drug that would be like the first line agent. So that would be the first type of agent that will be given on a new diagnosis of diabetes. So this is an insulin sensitizer, and also has an effect on reducing the glucose production in the liver. So metformin, very well tolerated, little or no risk of hypoglycemia, but they can cause GI disturbances. They can reduce the appetite, cause nausea and diarrhea, and also may reduce the vitamin B12 absorption. One thing that it's important to point out is that there is a black box warning and can cause lactic acidosis if improperly prescribed, but otherwise pretty well tolerated. Now, the next class of insulin synthesizers are the glitazone. So the glitazone are insulin synthesizer, and they also suppress the hepatic glucose production. And so the agents are pioglitazone and rosiglitazone. This class of agent has a black box warning because it increases the risk of heart failure and potential increased risk for heart attack. So they have to be prescribed with caution. And pioglitazone may have less, maybe less adverse effect, less risk, but still the black box warning is there than rosiglitazone. So this is actose. They can also cause fluid retention and edema and weight gain. So this is another drug that will increase the weight, and so it can also increase HDL, LDL cholesterol, and triglyceride. Now, the third type of mechanism of action is regarding the drug that delayed the intestinal carbohydrate absorption. So by reducing the absorption of carbohydrate, you reduce the rise of blood glucose level after meal. And this include the alpha-glucosidase inhibitors. So they retard the degradation of polysaccharide into monosaccharide. The drugs are acarbose and miglitol. Adverse effect, this is important for you to know, because if you are in the room with a patient who is on acarbose, you may want to know that they have increased risk of flatulences. And then they can also cause diarrhea and abdominal discomfort. So the next group of agents are the GLP-1 and the incretin enhancers. So these are newer oral hypoglycemic drugs. They are newer agents. And first you have the dipeptyl peptidase 4 inhibitor, so the DDP4 inhibitor. So first of all, what is GLP-1? So it's called the glucagon-like peptide 1. So it's also a peptide hormone that is produced, and this one is produced in the gut and will increase insulin secretion after a meal. So, and it will also reduce the secretion of glucagon and slow down gastric emptying, and therefore will reduce the postprandial level of glucose and improve satiety. So GLP-1 has a half-life, you see it's very short, 1 to 2 minutes, and it's degraded by the dipeptyl peptidase 4, so degraded by that enzyme. So how does dipeptyl peptidase 4 inhibitor work? They will prevent the degradation of incretin, and therefore you will increase insulin secretion, and you will that will help reducing the level of glucose. And those drugs are the gliptin drugs. So they are active orally, which is great because they increase, the effect of insulin, but it's an oral agent. So these are the sitagliptin, the saxagliptin, and the linagliptin. So you see they all have the same terminal ending. Adverse effect, they can cause nasopharyngitis, UTI. They can cause hypoglycemia. Of course, they are hypoglycemic agent. The advantage of this one is that they are weight neutral. They don't cause weight gain. Now you have the next class of agent, which is the sodium glucose cotransporter inhibitor, the SGLT2 inhibitors. So this is also a newer type of oral hypoglycemic agent. So this transporter is expressed in the proximal renal tubule and is responsible for the reabsorption of glucose in the kidney. So if you inhibit those transporters, then you prevent the renal reabsorption of glucose, and therefore you increase the urinary excretion of glucose. It's also a drug that is active orally, and these are the gliflozin drugs, so canagliflozin, empagliflozin, and dapagliflozin. And adverse effect, of course, these are hypoglycemic drugs, so they can cause hypoglycemia. Female genital mycotic infection, UTI, and increased urination are common side effects because they act on the urinary tract. More severe reaction are ketoacidosis and acute injury of the kidney. So here I have this picture of Georgian. So this is my daughter's acting coach actually, and she just recently shoots a commercial for Georgians, which is one of the CGL2 inhibitor, and she actually went to South Africa to shoot this commercial right before COVID hit. And you may have seen the commercial on TV, and if you have not, you can just click on the link here. Now you have the new injectable hypoglycemic drug. So until now we talk about all oral hypoglycemic. So when you study, make sure that you know which one are oral, which one are injectable, and your different type of insulin. So the new injectable are the Increating mimetic. So these are the GLP-1 agonists. So they are similar to GLP-1, and you remember I said that GLP-1 it's a peptide hormone or peptide. Yeah, it's a peptide hormone. So therefore cannot be injected. So it's an analog of GLP and part of the Increating family. So reduce the postprandial level of glucose. Same effect, going to suppress the appetite, and one advantage, it may result in weight loss. Because it's a peptide hormone, this is administered sub-Q, and this is exenatide or beta. And then you have biduron, which is the same, but it's an extended release. And then you have liraglutide. Those agents can be used as a monotherapy, but they can also be used added on to other oral hypoglycemic in the management of type 2 diabetes. Adverse effects can cause nausea, diarrhea, hypoglycemia, of course, and then weight loss, which is it's an advantage in patients who are overweight. And then there is a black box warning that because thyroid cancer were seen in rats. And then this is another injectable drug. So this one is an analog of amylin. So amylin, it's a neuroendocrine peptide that is produced by the pancreatic B cells, just like the same cells that produce insulin, and it's released with insulin to assist the postprandial glucose control. So it's also slowing down the gastric emptying, just like GLP, and it also reduce the glucagon secretion and increase the satiety. So overall, this amylin also reduces the postprandial level of glucose because it's also a peptide hormone. It's administered sub-Q, and this is pramlintide, Stimlin. And this one can be used in type 1 diabetes, but it's a supplement, so it's used in conjunction with mealtime insulin, either in type 1 or type 2 diabetes. Again, adverse effect, it's an hypoglycemic agent, so there is a risk of hypoglycemia. And there is a black box warning that the co-administration with insulin may induce severe hypoglycemia. And so this usually occurs within 3 hours following administration. So tight control of insulin, it's important to avoid severe hypoglycemia. Now this slide is just a summary of kind of like the steps in the treatment of diabetes, but I'm not asking you to know all those steps, but I think it's good to know which agent are first line monotherapy, and then which one can be add-on to metformin as dual therapy if the patient are not at goal. So you see if the patient is as an A1C less than 7.5, these are the agent of choice, and if their A1C remain higher than 6.5 after 3 months, then they would add a second agent. And so you would have metformin first, and then you can have either GLP-1, DPP-4, and after that you would have a triple therapy if the A1C is still above 7.5, or here you see if the entry is higher than 9, the A1C higher than 9, with symptoms, they would start with insulin, and then they will add some of those oral agent. If they have no symptoms, they will treat with a dual or triple therapy of those oral hypoglycemic. And then this last slide is just a summary of your adverse effects. So which one can cause severe hypoglycemia? Of course, insulin is the one in red. And then you see those were pretty neutral, but then you see sulfonylurea that have moderate to severe hypoglycemia. Now for weight loss, you see those that can cause weight loss, those that cause weight gain. The one that can cause a renal adverse effect and GI adverse effect, and then the one that has effect on heart failure, cardiovascular disease, which one are at risk, which one can have some beneficial effect when they are used. So I thank you for listening this lecture on diabetes, and then I will move on to the other endocrine disorder.